very much. So, David's up there. So, Oxford is supporting us on this. Jane's over here as well. I've got the, questions? Yes, please. Jane, everyone. Questions?
I've now got Professor Blaisley beside me. I wanted to go back to what I was saying about ideal, because you repeatedly emphasised the lack of consensus. And this is absolutely typical of surgical issues. So one thing I'd say you might consider is doing a proper big national audit for a while, not necessarily a long while first, to try and sort out that lack of consensus. If your audit shows that a lot of these controversies actually it doesn't matter which surgery you use, it doesn't matter whether it's continuous, then you can forget about it and say, do what you like.
Yeah.
But without that consensus building process, some of these things may trip you up. The other point I have, and I think Jane's probably going to say the same here, is outcomes. I think we need to think very carefully about outcomes. I can see some potential problems with that. But you flashed a very interesting slide that you didn't talk about, which said what, as far as I could see, it was only on for a second, it was about what people thought were important.
Yeah.
And the big bar at the bottom was final appearance. Now, if that's what people think is important, that's what they'll be interested in doing a trial. And forcing them to do a trial on something else will make them unhappy.
Yes.
So I would think
Well,
there's
we did
still a
talk
bit of work
about
to be
this.
done about
Because we thought about looking at the final appearance of the year, and then you have to get somebody to assess it, and then you can take photographs, and then photographs are difficult to assess. And then who do you get as an assessor, and how do you grade it? And it's not very easy.
There's a grading system, and that's going to be part of the trial protocol, and that's where we'll look at that.
Yeah.
But the question we started with does your nail look pretty at a year? It was, is there an increased infection rate, which is a clinically important question, because infection has associated morbidity, cost, etc., and inconvenience for patients. So I accept that. Also, speaking to the NIHR, as a plastic surgeon, if I go to them and go, I'd like to do a nail bed trial to see if the nail looks pretty at 1 year, will you fund me? I can guarantee you they won't. So we have to have some, this is my opinion, this is my, having failed at NIHR grants before, maybe that's a secondary question, I don't know. David's going to help me on this one.
Just an observation from me. I think very well done, Amy, thank you. But the variation is good to some extent because it exemplifies the uncertainty. But it makes the question, so I'm really keen on having a really key and sharp question for these things. It makes that question definition quite difficult. Have you got an idea about the next stage, how you might tease that out? Apart from these national surveys, because at the moment you're collecting lots of data to show all sorts of things happening. What would be the next stage?
Well, what we did do, we had this meeting, everyone was invited, everyone at BSSH, 22 people turned up, we're discussing it today, we've got hand surgeons in the audience. We've asked the 112 surgeons, put out to everyone, what are your important goals? And really flick to that slide and what the Survey Monkey showed. So it's a difference. What the surgeon thinks is important, what the patient thinks is important. That always is the case, pretty much. In hand surgery, we go function, patient goes looks. It happens in rheumatoid arthritis quite often. So we need to marry those two, but we're also trying to get a successful trial that can be funded. Now, go on, Jake, tell me.
So I was going to ask about that. I was going to say it's great what's going on, it's fantastic, and we've done loads of brilliant work. But what you need to do is write the full grant application.
Yeah.
And then you don't put in your ethics yet, you just need to write the full grant application, which will need a little bit more. You've got lots of the right people involved, but it's not quite there yet. And over that time, they're going to have to, I wouldn't recommend going ahead without having it.
Okay, we had this discussion about whether we do that way, but then we thought we may need to get some pilot or feasibility data potentially to run into that. For that you need ethics, I'm assuming. That's what we discussed. That's really ethics. So we've had this discussion, and David we did have an hour about it, whether we should or shouldn't do the grant or shouldn't. The answer is I don't know. I'm not experienced enough, and we're going to be guided. We've got 2 trials units, 2 separate views.
Not really the point of the
importance. I sit on one of the HTA panels, and we've recently been asked to look at 2 trials which are going to cost a huge amount of money about runny noses. Okay. Now, I don't want to be rude about runny noses, but I didn't think that this was a particularly good use of NIHR money, and found myself in a very distinct minority because they were very well designed trials. So, I think that, I can understand why you're worried about that, but I wouldn't worry that much about it if you took a tight answer to a question.
do you think how the nail looks is important at a year, or do you have a short-term infection early on? What do you think? Okay, hands up for the way it looks at a year. Okay, hands up if you think there's an infection. Because it looks, so that's different to our national survey here. So,
infection to be treated as an infection. Is it for appearance? So actually, briefly doing operation,
okay, but that takes us back. But bring it back to the question. The question was, the nail going back in. You put the nail back in. It's that one step in the surgery, replacing the nail, whether that can make a difference to the outcome, i.e., reduce the infection by not putting the nail back in. But what we're hoping to find is that, yeah, okay, maybe that's not the right question. Maybe we're changing it completely. So maybe we're looking at actually, what I think is that it really doesn't make a difference with the nail back in or not to your outcome, which will be cosmesis. So maybe we should change the primary outcome to cosmesis. Do you think? Manu, go on.
Can I just say, that's a very important statement. You've got two things, neighborhood and appearance. And we're actually talking about three different things here.
Yeah.
Appearance is what we see, but actually the functional performance of the neighborhood is completely different. If you have a poor outcome from a nail repair, it's not just the appearance. The period infections, nail lifts off, patient in pain, catches the racing. You need to tease that out as an outcome because they're not the same thing. They can't be put together.
Is this from, which one is this
This
from?
is from the online survey.
So this is online, so this is surgeons. So surgeons think appearance here.
You can't group the two things. They're two different things. What it looks like and how they will and what you know is different things.
Yeah.
Similar to the previous comments, is there any evidence to suggest that infection and appearance are correlated in any way? Because it might be that you could throw it together as kind of one outcome if there's a relation.
So early infection, what do you think? Early infection,
I do think, let's say, I think it is the wrong question you're asking.
Okay.
I think outcome is appearance. That's what parents want to know. Complications would be an infection or pain or whatever. But actually the outcome, the reason why we're persuading them to when we're doing this operation
Yes.
is so that they'll Johnny's nail is missing.
Yes, that's right.
Do we know the answer to that question? Do we know an operation is going to make that nail pressure?
Well, that comes
okay, now we're taking this, we're doing, change the study now. There's that's operation versus no operation. That's
You can see
later
why
on.
it took so long in February.
Yeah.
See me moving up.
In February, yeah. We had all this. All this has been gone through once already, and we're just digging it up again.
Abby, that's okay, because if it isn't settled, that discussion does need to occur, because it clearly isn't at that right point yet. And these processes do take a long time, and we can't rush it. We do have to, if there are concerns out there, and we haven't nailed it down so that you're addressing the clinical problem, which it sounds like we are trying to do now, if there's no consensus on what the critical question is, we have no obligation but to go around and make sure that we get to that.
So can I just split? So what we're discussing here is to repair a nail or not repair a nail. Is that what we're asking here?
Why can't you have repair, not repair? If you repair, you randomise it to nail or no nail.
Okay,
Why not have multiple arms?
Okay, so my concern with to randomise to not repair, to repair, is these, you can see most of these surgeries are done by junior doctors unsupervised. We know, and Manu, we talked about this, I think you should probably repair a nail, certainly the majority of them, that's severe crush. Are you comfortable to allow a child to be randomised by a junior doctor at night, probably, to a non-repair arm? Would you allow that to happen? Because consensus, well, in the discussion, most surgeons wouldn't be comfortable with that. That's why we're not doing no repair. We're not doing that. James, you were there that meeting.
These non-repair, 50% of them have an open fracture.
Yeah.
So that I think is a big, may have a big impact on the infection rate and the complications as a result of that. Bone infection rather than just a superficial.
Please get